When I wonder, my God, where we are and now what are they doing? So this is the thing.
Exactly. Another important things will be again found in contrast CT scan, the external extension. The things will be changed. If it is external extension, the mind change of the surgeon and radiation oncologist also will be changed. So external extension is very much important in contrast CT scan. We have examined in clinically hard fix, but CT scan also have.
So, Professor Monila, chairperson, wants to add something.
Actually, the question is that how much extension we will see by CT scan or MRI in this case. Firstly, we have to decide whether it is adenocarcinoma or it is a small cell carcinoma. If it is adenocarcinoma, there is no way to escape to do a CT scan or MRI from picoid cartilage to pubic symphysis. That is the landmark given in the books, the standard books. And there is some battery of tests varies from country to country. Professor Martin, I called him always because he is my young older brother. আমাদের পূর্বসূরি তো উনি যেটা বলছেন হি নোজ ইট বেটার যে ইংল্যান্ডে একরকম প্রোটোকল ফলো করা হয়, আমেরিকাতে আরও 11টা টেস্ট বেশি করা হয়, 3টা টেস্ট বেশি করা হয়। এটা কান্ট্রি টু কান্ট্রি তার প্রোটোকল সেট আপ করে। আমাদের দেশে এরকম কোনো প্রোটোকল সেট আপ করা নেই। বাট ইন কেস অফ আননোন প্রাইমারি ইউ হ্যাভ টু ডিসাইড ফার্স্ট হোয়াট ইজ দ্য প্যাথোলজিক্যাল নেচার, হিস্টোরিক্যাল নেচার অফ দ্যাট।
Yes, Professor Monila, we are trying to make this unknown primary to a known primary. So that is
moderator sir. Question is that whenever you do a FNAC, final aspiration biopsy, we call it now. FNAP করার পরে আপনি ধারণা করতে পারছেন যে এটা কোথা থেকে আসছে মোটামুটি। কেন? যদি স্কোয়ামাস সেল কার্সিনোমা হয়, it will come above cervical curve, 85% কেসে। যদি অ্যাডেনোকার্সিনোমা হয়, 85% কেসে it will come below the curve. So your investigation protocol
এটা তো বলে না
এখানে বিফোর ডিসকাসিং অ্যাবাউট দ্য ইমেজিং আমরা এখনো সাইটোলজি কনফার্ম করি না। ইন্ডিয়ার কেসে আমাদের ইমিউনোসাইটোকেমিস্ট্রি করতে হতো। আমি মনে করি
with the proceedings we will
আসবে, ঠিক আছে। আরেকটা জিনিস যেটা মতিন স্যার যেটা বলছেন যে অ্যাবডোমেন এটা তো কান্ট্রি না সেন্টারও ভ্যারি করতে পারে, বাট ইন কেস অফ আননোন প্রাইমারি উই মাস্ট
এন্ড বোন উইন্ডো লাগবে।
Not only that, we must examine the scrotum testes as well.
তাহলে কালকে
I will show you the neck part. So we have done CT scan of the neck, pre and post contrast view, and the result is that is one
মাঝখানে
there and nothing
সেন্ট্রাল নেক্রোসিস
contributory. MRI neck is also says only the mass and it is free from any dead vessels. We have done HRCT scan of chest, that is also begins normal, and what Babur Bhai has correctly said, that we have done also ultrasonogram of whole abdomen, and that is also normal. So again I back to the previous slide. We didn't discuss about the metabolic imaging, that is PET CT scan, which is very new investigation for our perspective, and it is not common in our country. So I like to again from the auditory panel, jury panel, I like to ask again Dr. Mahbub about the metabolic imaging. What PET CT information we will get in this case? We didn't do the PET CT of this case, but if we do, what information we can get from it?
সেটা কি ইয়া করবে, সেটা মেটাবলিক ইয়া শো করবে কিনা?
Combination of CT scan and
PET CT
says PET CT. CT scan shows the structure of anatomical of lesion, and PET shows the function of the lesion. Here use radioisotope or FDG or fluorodeoxyglucose. So the total name is FDG PET CT. FDG is a radioisotope. You can given intravenously after 30 or 45 minutes, patient is sent to the imaging table here from skull to the mid thigh. Usually to the mid thigh বল দাও হ্যালো
হ্যাঁ আশিক ভাই
স্যার আসসালামু আলাইকুম স্যার
হ্যাঁ বলেন বলেন
from the audience there is a request to after closing my presentation okay sir this is my final position of the presentation okay I use this to estimation and to augment the presentation at the base of the tongue okay hello
okay thank you Ashik bhai
okay you go on okay
Okay.
Mahmood bhai
okay I'm continuing
Hi, Mahmood bhai.
uh-huh.
For your kind information, after your panel discussion, there are two presentations and then there is a live surgery. So
Okay.
You should keep your time perfectly.
Okay, thank you.
Okay,
Thank you. Okay, so I like to ask Dr. Kamal, who is a medical oncologist and working in our NIENT hospital, radiation oncologist. So what the information on the face? Session? Okay.
From brain up to the mid thigh is imaged in the CT scan and here the uptake of FDG. The lesion uptakes the FDG and when CT scan the patient is when CT imaging the uptake abnormal uptake area was the signal of metabolic activity of the lesion.
Okay, so my question is, so in this case, carcinoma unknown primary neck, in this case, what information we can get from there, from PET CT, post pre-operatively and like, so I like to also contribute from the Kamal bhai.
Such any primary above 0.7 cm or 1 cm in from brain to the mid thigh, it can be identified with uptake of the FDG. But sir, few lesions that does not take the FDG out. That is mucinous adenocarcinoma of the ovary and follow neuroendocrine tumor. That does not show any activity. So these will be
Okay, Dr. Kamal, you want to add something?
Very good.
নেকে যদি বাল্কি টিউমার থাকে এফডিজি করে খুব একটা লাভ
FBT.
নাই।
As
কারণ
well,
ওই
FBT,
পুরোটা নিয়ে নেবে।
So classical আমি
যাবেই।
ধরে নিচ্ছি, 200
করছিলাম না, false negative কোথায় হয়?
So the FBT
একটা হচ্ছে ইনফ্লামেটরি লেশন আর একটা হচ্ছে বাল্কি টিউমার ইন দ্য নেক।
right left consider area. So তার বলে দিচ্ছি কিন্তু what is the lesion?
So
What
if
is
we
the
do
deposit?
a PET CT in this case, we can have the,
Yeah.
we can locate the primary
Exactly
site.
primary. So
Okay,
and
that's
then
Directional biopsy নিতে পারবো।
guideline.
50% অনেক তো।
Imaging
যে আমরা
actually is a
চারটা
huge
বলছিলাম
thing
না
here.
যে
So
50% আপনার
if I come back that what imaging we will be doing, there was a debate doing chest CT and abdomen. Unless we declare, once we declare it as an unknown primary, then we need to search for the primary. If I find something in the neck, I don't need to go to the chest and abdomen. So why the step by step is done, we do the next up to the mid chest, we look for the primary, and if I find something in the neck, then the importance of searching for other become less important. If I don't find something in the neck, then it becomes more important to go, number one. Number two, coming back to this case, that normally no imaging is 100% complete. CT scan, all data says that gives you 55% information. MRI is complementary, not for every side, for base time, for NPC in head and neck, MRI is good. Now diffusion-rated MRI image gives a very good information. And also, before CT was superior for neck node, now MRI is almost equal to neck node. So it is complementary. We cannot say that we do CT, we do MRI. So if we do both, we will get a complete information. Beyond this, sometimes MRI miss some of the lesion which can be picked up by PET CT. PET CT says that 25% upstaging of neck node is done by PET CT. And even some base tongue lesion or very small lesion of the parapharyngeal space or even the NPC which we missed by MRI may be picked up. But one thing, there are some normal uptake like tonsillar fossa. SUV is high normally. That should not be mistaken as primary. So when we are reading PET CT, we need to be very cautious that whether it is a normal uptake or a pathological uptake. Thank
টনসিলে
you.
বেশি নাই।
Thank you, Dr. Kamal. Let us proceed. We are already short of
টনসিলে
time.
কম
So,
এরকম শুনি
in
নাই
this
তো।
patient, we have done
থাইরয়েডে
both
হাই
this
ভাস্কুলার
type of
আছে
this
সেটা একটা ব্যাপার।
sort of imaging. So what is next? We are following the American Association of Head Neck Oncology guideline for the NCAP, neck carcinoma of unknown primary. So next step is advanced pathological and molecular diagnosis. We have heard many times that Epstein-Barr virus relation, HPV virus relation, P16 positive, P16 negative. So we are not very familiar with this investigation, and we usually do not most of the time advise. So I like to first ask Dr. Abdul Karim Mitu. He just returned back from USA. So what is the protocol followed in USA in this regard? The advanced pathological and molecular diagnosis in MSKK, MSKCC and in the Harvard Medical. Just in a brief.
থ্যাংক ইউ স্যার। এখানে একটা ব্যাপার হলো কোর ডিফারেন্সিয়েটেড কার্সিনোমা। এখন আমার সেই নির্ধারণ অবশ্যই আমাকে কোর করতে হবে, ইমিউনোহিস্টোকেমিস্ট্রি করতে হবে। ওরা সাধারণত ইমিউনোহিস্টোকেমিস্ট্রিতে হিউম্যান প্যাপিলোমা ভাইরাস দেখে এবং এপস্টেইন-বার ভাইরাস দেখে। এই দুইটা ভাইরাস মাস্ট করা দেখবে।
That is a protocol, routine protocol.
Routine protocol in every case.
So we must also follow this protocol. I like to ask our histopathologist Taslima Appa, head neck histopathologist, will you please, in a very short form, what will be the advice? How much tissue is required to do this molecular testing, and what will be the outcome, and what is the P16 positive and what is the P16?
Case poorly differentiated or metastatic poorly differentiated carcinoma, we have to do core biopsy or open biopsy. Then I have to confirm whether it is squamous cell carcinoma or adenocarcinoma or neuroendocrine carcinoma or undifferentiated carcinoma, and then HPV detection by immunohistochemistry P16. If P16 is positive, then definitely it may be from oropharyngeal. We can, if the tumor is not identified, in spite of that, treatment plan can be.
Yes, exactly. So the take-home message is, it is very much available now in our country, immunohistochemistry. So in this case, if the case scenario is like this, head neck cancer treatment, we must include this immunohistochemistry examination. Okay, we proceed to the next slide. What is next? We do not do immunohistochemistry in this case. So, sorry, I missed one thing. So, how much tissue? Is it possible to do the immunohistochemistry from FNAC sample?
No.
How much tissue do you have? Or you need core biopsy is okay? So, if we do core biopsy and send the tissue for immunohistochemistry, we can detect whether it is
আমরা কেন কোর বায়োপসি করি না? কোর বায়োপসি খুব কঠিন, বেস্ট কোশ্চেন আমরা
scenario become changed on patient perspective. So next, the endoscopic and other procedures, that is a triple endoscopy we usually do, and then narrowband imaging, a tonsillectomy, circumferential oropharyngeal resection, which we usually do not practice. Our teachers practice or not, the tonsillectomy and circumferential oropharyngeal resection, transoral robotic surgery is not possible in our country, transoral laser microsurgery. This is the protocol which is advised by the American Association of Head Neck Oncology back in 2020. This is the latest protocol they are following for NCT. So, will you add anything on this investigation, on surgical point of view? Dr. Mahmood Hassan sir, will you please, on this pan endoscopy, narrowband imaging, tonsillectomy, circumferential.
এনবিআই নতুন করে নিয়ে আসছে, এই আমার এনবিআই।
প্যান বলতে কি
তিনটা
About pan endoscopy. While we are
Pan endoscopy.
we used to do laryngoscopy, pharyngoscopy, esophagus and bronchoscopy. But nowadays, with the advancement of technology, we are doing in our center transnasal esophagoscopy, transnasal bronchoscopy, laryngoscopy, pharyngoscopy, everything. The pan endoscopy is an office procedure nowadays. So we can practice in every center. I think this institute is very rich in instruments.
Yes, we have done this endoscopy.
Yes, we can practice transnasal esophagoscopy, bronchoscopy, everything as office procedure.
So what American Association of Head Neck Oncology suggested a triple endoscopy, only 3. Direct laryngoscopy, rigid and flexible bronchoscopy, rigid or flexible esophagoscopy. So these 3 is the triple endoscopy they suggested in this case. So I like to proceed further because we have
Isabel
first
Escobar
time
নাকি?
about
আবার দিয়ে
narrowband
endoscopy।
imaging.
ওই তো,
So
Isabel
these
Escobar।
two investigation, they suggested
কিন্তু triple
we
endoscopy
give
তো-
unknown primary
তাহলে
to
triple
look
endoscopy
at
পরীক্ষা সময় বললো তো ওই তো মানবে না।
investigations, molecular pathology, and another one is narrowband imaging. And you all know that I am doing fiber optic laryngoscopy for many times, and in our institute we have a fiber optic laryngoscope machine that has narrowband imaging also. So what narrowband imaging can give us? So if we see this photograph,
NDI আমার
so this
যেভাবে
is
ঝাঁকানি
the
দিয়েছে
normal picture of a fiber optic laryngoscope procedure, and this is when the light has been passed. This is normal, what we think, and whenever we put the narrowband imaging light option, so the picture becomes like this. So this is actually, we think this is normal, but when we use the narrowband imaging, it becomes like this. So in the narrowband imaging, we use two light actually, and the vein color is in the submucosa becomes cyan, that is samogre dever color, and brown is the capillary color. So minimal changes we can detect from there. How much? Only 5 millimeter lesion. If there is only 5 millimeter lesion in the larynx, we can detect whether there is the known primary is in there or in some other place. I proceed with these things. So, yes. Yes. And we can take biopsy from there also. There's a biopsy channel.
Sir, again, sir, sometimes leukopenia and malignancy can be
না
confusion.
ইয়া নাই তো
And there are some vessels, as Mamu said, green light and blue light.
এটা আছে জি ভাই
We can differentiate by into deep vessels and
আমার favorite
superficial
question
vessels like mucosal capillary.
I like to share one more thing, sir. In iPhone, there is an option also in this narrowband imaging option. So from iPhone, if we take a picture and we can color change it, sometimes it's possible. And there is a software also that artificial intelligence, there are so many photographs of this larynx. So in a fraction of second, they can match the photographs and the efficacy rate is 87% with that iPhone. We can detect whether this is a cancer or every cancer has not. Okay, let me proceed. So this is the American Association of Ethnic Oncology protocol that we usually follow. We will clinically evaluate the patient. We will do fine needle aspiration biopsy, core biopsy, or open biopsy. The imaging is ultrasound, cross-sectional imaging, metabolic imaging, advanced pathological and molecular diagnosis, very much possible in our country. So in our institute, we are regularly practicing if there is any problem. So endoscopic procedure, pan endoscopy is very common in our country, narrowband imaging. We are already expertise on this right now. Tonsillectomy, circumferential oropharyngeal resection, transoral robotic surgery, and transoral laser microsurgery is not practiced in our country, but it can be practiced. And Azad, will you add something on that? The directional biopsy or anything?
Sir, in MD Anderson, I have seen routinely what they are practicing. Actually, every patient they are
50%
doing
অনেক
trial.
বেশি না
Every patient,
মানে
without
আপনার
trial, they are
পেট
not
সিটিতে
seeing
পজিটিভ আছে
patient. So what they are doing,
যদি প্রাইমারি খুঁজে পান
conventionally,
আমাদের একটা পেশেন্টের
everything
মধ্যে
they have done,
মানে
PET
5
CT
বছর
also, finally PET CT.
5 বছর না 1 বছর আগে তার অপারেশন হয়েছিল কাপের এমআরএনডি করা এখন বাড়ি ভাঙা পোশাক খুঁজ নিয়ে আসছে
bilateral tonsillectomy they are doing.
এদিকে আবার
Then
নোট
from the tongue base, from the special
একটা
from the
মহিলা
lingual
শুয়ে আছে
tonsil.
দেখেন
Before doing this, they are also finding that there is any contact bleeding or ulceration or unhealthy mucosa or submucosal irregularity or leukopenia.
Okay, I got your point, Azad.
Yes.
So there is nothing called blind biopsy.
No blind
So
biopsy.
there is no blind biopsy procedure
What
right now.
they are doing
You have to see
bilateral
and take
tonsillectomy and tongue base, from the tongue base they are doing the biopsy. After that they are doing this tissue, from this tissue they are doing the
Professor
HPV
Enamoti, one
and external.
Yeah, so actually, just my experiences. Last 10 cases I have done pan endoscopic biopsy. The routine procedure, as you said, we have what we have there, bilateral tonsillectomy and tongue-based mucosectomy. That is our procedure, no other.
So out of the 10, I got 1 positive from the left tonsil recently. So this is the protocol now there.
Okay, what American Association of Head Neck Oncology says, unknown primary will, the term will be soon obsolete with the advancement of the different investigation. Right now, if we follow this protocol, only 5% of the cases will be unknown primary. And rest 95% from unknown primary, it will be known primary.
আমাদের তো সব 100% আননোন হয়।
ইমিউনোহিস্টোকেমিস্ট্রিতে যদি বলে এসপিবি পজিটিভ, দেন যদি আমি নির্দিষ্ট করে কোনো লেশন না পাই, কোনো ফ্যারিংস, দেন ওরা সরাসরি ইয়েতে চলে যায়, রেডিওথেরাপিতে চলে যায়। যদি কোনো লেশন পাওয়া যায়,
Okay, we'll come to that point. So
bilateral why? Because 10% cases another tonsil তারা সেই জন্য initially they tried for unilateral tonsillectomy, but now they started bilateral tonsillectomy. কেন? কারণ ক্রিপ্টের ভিতরে so small lesion they can get it.
okay, so undiscovered primaries after extensive searching at the unit, only 5% cases we will get NCUP. So what Scott Brown says, what is the definition of NCAP? The new term is NCAP, that means neck carcinoma of unknown primary. What Scott Brown 8th edition legislation says? What is NCAP? NCAP is the presentation of metastatic neck lymphadenopathy without the development of manifestation of an index primary tumor within subsequent 5-year period. NCAP is diagnosed in a patient who presents biopsy-proven SCC, absence of obvious primary despite rigorous clinical examination, appropriate cross-sectional imaging, examination under anesthesia, ipsilateral tonsillectomy, biopsy from tongue-based mucosa or formal mucosectomy, plus minus biopsy from mucosa post-nasal space, and or ipsilateral pyrotransmission. This is the definition provided in latest edition of Scott Brown. So let us proceed. So our working diagnosis, that is our limitation. We do not do anything further. Our working diagnosis is NCAP, that is metastatic poorly differentiated carcinoma. So we have many limitations, but till now the diagnosis is NCAP, metastatic poorly differentiated. Are you happy with the diagnosis? From there we will go to the further treatment. Yes, analyst.
I think
We will go for surgery from there.
But before surgery, it is squamous cell adenocarcinoma. I must know it because the treatment protocol will be changed. And for this, I need to do a core biopsy, core needle biopsy.
You do want to add something?
লাগবে ইমিউনোহিস্টোকেমিস্ট্রি লাগবেই, কারণ এটা অ্যানাপ্লাস্টিক কিছু হইতে পারে।
So if we are there only in 2 cases, if it is inoperable or after the surgery. So yes, as oncologist, I need to have the maximum information. But in the real world, after even doing immunohistochemistry, in 100% cases you cannot identify everything. But as Azad said, definitely if there is an option, I will go for core biopsy. I will chase everything to find the primary or find the time.
So we will go for proceed for treatment from here. I totally disagree with the panelists because medical legally and on patient's perspective, we want to give comprehensive head neck cancer care to the patient. So we must go through the tumor board. Unless the decision is taken from the tumor board, we cannot proceed for the further treatment.
Without treatment board, MDT.
Okay, thank you. So we had a tumor board in NIENT. Regularly it is going to happen. It is happening since many days, and on Sunday
In 2A.
around 12 p.m. So we all in NIENT are present there, and with
2A মানে
radiation
আপনার 3
oncologist,
সেন্টিমিটার 3 থেকে 6 সেন্টিমিটার মধ্যে
3 থেকে
6 সেন্টিমিটার
অথবা
So this scan
অথবা
is presented to the tumor board at 65 years old. The diagnosis is NCAP. The tumor location is
2A-তে
labeled
সিঙ্গেল
on
মাল্টিপল
CM
ল্যাটেরাল
in the right side.
এবং তার
TNM
সাইজ আছে 3 থেকে 6
staging is
সেন্টিমিটার।
N2A,
Multiple হতে পারে না
N0.
2A-তে?
না।
First treatment, none.
মাল্টিপল ইয়াতে
So happy with this?
দিতে
দিতে ইপসিল্যাটারাল
I don't think so. Because the tumor size was 3 centimeter by 3
মানে
centimeter.
কন্ট্রালেটারাল হতে পারে আপনার
In the CT
মানে
scan, exactly.
দুই
Single
পাশেই
will
On
আবার size যদি
palpation,
size বেশি
it
হয়ে
was
যায়।
3 by 3 centimeter. and
মাল্টিপল
CT scan
কন্ট্রালেটারাল
is 4
বাইলেটারাল
centimeter by 4
সব
centimeter. And on MRI, it becomes 4.5 to 4 centimeter. That is why
স্টেজিং কেন্দ্রে গোলটা বলা
rated it as N2A. So, the working diagnosis till then, with all our limitations, it is still metastatic poorly differentiated carcinoma. MCAS. So, what is the treatment plan? What the tumor board will suggest? We cannot differentiate
decision
it
করে দেব।
from the squamous cell or
R&D
adenocarcinoma.
করবে আর কি।
Think it may squamous cell carcinoma, think it as adenocarcinoma. What will be the outcome?
Operable. Operable, আমি operable.
If it is operable, then straightforward modified radical neck dissection, then final histopathology, then radiation
So it
oncology
is very
will
much operable
take
because
over.
it is not associated with the blood vessels and the tumor is confined, so it doesn't show any attachment with the blood vessels. So it is operable. Kamal bhai, do you agree with it? Or will
I totally agree because some of the colleagues sometimes call me that can we do some induction on new treatment. Just for the information for the colleagues, there is no role of induction chemotherapy in this situation. The recommendation is level 3, the poorest recommendation. If it is inoperable, we can go for chemoradiotherapy, but not for chemotherapy. Only very limited site of Tata and this Shaukat Khanum, they are doing total N3 disease, marginally resectable. They give 2 to 3 cycle chemotherapy, then go. Otherwise, please don't take us in the scene to do induction. Either surgery or chemotherapy, no induction chemotherapy.
Sir, one question to you, sir. If it is N1 disease mobile, the single modality treatment for metastatic unknown primary, radiotherapy or surgery. So if I press to you, what is your opinion regarding radiation, upfront radiation?
So if any modality, two modality have equal outcome, then patient will take the decision, not me.
Thank you, sir.
So tumor board recommendation is surgery followed by adjuvant therapy. And I like to ask Dr. Shoro. So what is the surgery you will prefer in this case? Think it is a metastatic only differentiated carcinoma. We cannot differentiate it whether it is adenocarcinoma or a squamous cell carcinoma.
Yes, sir.
So what surgery will you prefer?
Sir, I prefer it at least MRND, modified radical neck dissection.
Type
So will you differ with him?
তো পারো
So
Actually, see, this is metastatic neck node unknown primary. So I did not ever seen selective neck dissection in metastatic unknown primary. They are practicing always at least MRND.
So will it be bilateral?
I also say
Thank you. Yes,
You want to do unilateral?
1 to 5, 1 to 5.
Bilateral.
1 to 5, not bilateral, unilateral. 1 to
You
5.
want to do unilateral. So,
আমি ঘুমাচ্ছি না
Yes, thank you, Saurabh.
so if it is a squamous cell carcinoma, if it is adenocarcinoma, after post-operatively we can definitely can diagnose whether it is metastatic adenocarcinoma or something. We will do neck dissection and MRND on the right side. Okay, so Kamal bhai, the patient has been operated and sent to you.
So definitely patient was sent with a histopathology report. Before I say something, I need the report. What is the histopathology report?
Histopathology report is external extension present and it is squamous cell carcinoma.
Think it is a squamous cell carcinoma, what will be, then you will do.
So-
And if it is adenocarcinoma, what will you do?
So if there is no, we already know it was N2A, but we know 20% to 25% there is a change in after pathological staging.
External
So
extension
even
আছে।
if it is 2, then we need to know whether it's ENE or positive or not. If it is external extension is negative,
তার মানে
then
C তে
only
চলে
adjuvant
গেল।
radiotherapy will do. But if it is external extension is positive, then we need to give concurrent chemotherapy.
So is there any scope pre-operative radiochemotherapy? Anything?
Pre-operative, I said there is no role of chemotherapy, there is no role of radiochemotherapy, neoadjuvant, but if it is inoperable, then we can give radical chemoradiotherapy.
So I like to ask our chairperson, Professor Mahmood Hassan sir, my mentor. So as a whole, we have done, still patient is waiting for the surgery. So any suggestion from your point of view regarding all these panel discussion and tumor board decision in a total.
Sir Kamal and usually we do practice to do surgery first, then we go for chemoradiation. Usually this is the practice for the long time is going on. Now it is also going on without any change. But there is some changes in the investigation level. Also there is some new invent for the investigation to diagnose the primary. But about the treatment, this is the same almost 20 years or 25 years. So I think that after the surgery and radiotherapy, the more important thing is for the unknown primary is the follow-up. And how long you will be for